Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friends. Welcome to this week's episode of the Healing Pain Podcast. This week, we're discussing lower back pain and the role of physical therapy in managing this condition. My expert guest this week is Dr. Julie Fritz. She is a distinguished professor in the Department of Physical Therapy and Associate Dean for Research in the College of Health at the University of Utah in Salt Lake City. Her research has focused on examining non-pharmacologic treatments for persons with spinal pain, including clinical trials and health services research. Currently, Dr. Fritz leads research projects funded by PCORI, the Department of Defense, and the National Institutes of Health that focus on clinical trials evaluating non-pharmacologic treatments for persons with back pain and evaluating patient-centered outcomes as well as opioid use. On today's episode, we discuss why we should be concerned about how we approach low back pain in our medical system, what a typical care pathway looks like for most people seeking lower back care, the impact or use of imaging studies for treating and evaluating lower back pain, the impact of cost on healthcare utilization, the role of physical therapists as primary care providers for the treatment of back pain, and how early physical therapy is associated with decreased opioid use. Okay, without further ado, let's begin and let's meet Dr. Julie Fritz and learn all about low back pain. Hi there, Julie. Thanks for joining me this week.
Hi, Joe. Thanks for having me.
I'm excited to talk about all things back pain. When we look at kind of literature, or if you've been in clinical practice for some time, you know that back pain's common, right? It's almost like a headache. Everyone gets it at least probably once or maybe more in their lifetime. And, we don't really, like with a headache, we don't really approach it like it's this kind of big medical issue, so to speak. People get headaches and they kind of self-manage it. And for the most part, they go away. Why should we be concerned about how we treat back pain in our healthcare system?
Well, I think your analogy to headache is really interesting in that there's perhaps a degree of social perception that you're hinting at where people recognize that having headaches, or we could think of other ailments and aches and pains as kind of a normal part of the human experience. But back pain, I think many of us would agree, has been medicalized to a degree in our society, particularly where we don't have that perception that this is something that's part of living life as a human being that happens from time to time. So, I think we've created a situation as medical providers and where we've created enough concern on the part of people who experience back pain that many, for understandable reasons, believe that seeking out medical care is their best option. And sometimes that's certainly going to be the case, but other times it may start a kind of things that don't always end up where that individual thought they would be when they began that journey.
When I think of the treatment of back pain, there are just a multitude of options, right, for people. Everything from different types of practitioners to medications to things you can place on your body that supposedly make you feel better. What does and I know the word typical is hard, but what does a typical care pathway look for someone when they enter the healthcare system and they say, hey, I have this low back pain that's really bugging me?
Yeah, this is an interesting question because the challenge in answering it begins to really highlight the problem that we have in terms of medical care for back pain, which is one person's experience is one person's experience to a degree. Although, there are reports and data we can point to say most often when people make a decision to seek healthcare for back pain, they either do it with a primary care provider or a chiropractor. And that varies regionally across the country, but that's the reality of what care pathways look like at the start. What happens from there gets a little more varied, but it generally involves some sort of mix of imaging that still occurs for a lot of individuals, medication management that may involve nonsteroidals or Tylenol or other kinds of anti-inflammatory or medications that really aren't advocated for people with uncomplicated back pain, like opioids in particular. But those are a very common part of management. Then a whole bunch of other providers typically become involved, physical therapists certainly being among them. But where physical therapy in particular ends up showing up in this pathway is highly variable, and quite unpredictable to patients who are seeking care, which should be a troubling aspect of our healthcare system for all of us who are involved.
So primary pathway sounds like go to a primary care provider, secondary pathway to chiropractor. Some of that varies probably based on someone's insurance benefits, where they live, what their friends said to them, so to speak.
Absolutely.
And then maybe like third or fourth somewhere, physical therapy is in the mix, again, depending on a lot of different factors. I want to come back to our colleagues in chiropractic maybe later on in the episode. But I want to first talk about the management of back pain by a primary care provider. And I think when we say that, we're talking about an internist, so maybe a family medicine practitioner right now, because I know there's a lot of movement in our profession in physical therapy as physical therapists being primary care providers. But let's talk about kind of the more traditional route first. Let's take imaging first. What happens with imaging when someone with low back pain enters in the care pathway with a primary care health provider first?
Yeah, so data will show that radiographs, x-rays of people's backs, that's still a very common management on the first visit with the kind of healthcare provider that you're talking about, a primary care physician or advanced practice, PA nurse, the people who typically see someone as at their entry point into healthcare. And this is despite literally decades of data saying this is really low value care. X-rays for uncomplicated back pain, it's guidelines consistently advise against it. But it still happens in, a sizable percentage of cases based on healthcare data that we look at mostly from claims data. And it's problematic, not strictly speaking when we're talking about x-rays because of the cost. They're not a terribly expensive for a single x-ray, although in the aggregate, if you think about what the cost is to Medicare or something, that starts to become rather consequential. But it has, I think, an accelerator effect that we see with patients that we care for as physical therapists or other providers, where inevitably for somebody who's probably more than about 30 or 40 years old, things show up on that x-ray. They're often typical findings based on what happens to the spine as it ages, but it tends to accelerate a cascade of services in the pursuit of fixing what's deemed to be pathological about the spine. And that can have a lot of onward effects that, again, aren't always necessarily what the patient was seeking or really in the patient's best interest when they started that care journey.
So there's two things that I want to just touch on. So the accelerated effect is really interesting. So you're saying, obviously, once someone has an imaging study, they might see something on an x-ray, like some degeneration, for example, and there's a need to, as you mentioned early on, medicalize that, which means to treat it, so to speak. Should we not treat things we see on imaging studies?
Oftentimes, we shouldn't. It really comes down to a key question of whether an observed pathology is really even a part of a patient's symptomatic presentation. And even if it is a part of a symptomatic presentation, whether there's interventions that directly intervene on the pathology that are going to be helpful, like a surgical intervention. Even if a pathological finding we think with reasonable certainty is contributing to a patient's symptoms, it doesn't automatically lead to the conclusion that pulling it out, whatever it is going to be the best approach for the patient to take over the long term.
But don't we need imaging studies early on to make sure that there's not something dangerous there, like cancer or an infection or a fracture that might be there? What about that?
Well, sometimes, certainly. I mean, there are absolutely cases where imaging it would be considered probably negligent if it wasn't provided. The patient's history, their presentation, their signs and symptoms can lead a practitioner to make that determination based on the evidence that we have. the cases where that's the case, where that kind of decision making really makes sense based on the patient's presentation, are a relatively small percentage of the total number of people who present to a practitioner with back pain. So absolutely, the goal of never imaging back pain would be it wouldn't be a very patient-centered goal. But the proportion of use versus the proportion of patients where the clinical presentation really dictates that should be done is there's quite a differential there.
Because we're, of course, talking about red flags, right?
Sure. Yes.
Yeah. So, for example, Uncle Joe is on his ladder cleaning his gutters and falls off the ladder, and he has back pain that continues for 2 weeks. Probably a good case to look and see what's happening inside his spine with an imaging study, right?
Yeah, I absolutely, with that kind of a history of trauma, I think almost anybody would say that's really a very a necessary place for imaging to be able to understand what's going to be in that patient's best interest.
Yeah. I don't know, Sally, who works as a cashier in the local grocery store, stands on her feet 5 hours a day, most days of the week, and has no history of falling off a ladder, probably doesn't need an image.
Yeah, again, there'd be more you'd want to know about that particular individual, but in the absence of any other kind of strange finding or red flag, as you've rightly called it, yes, absolutely, that individual, which is far more common of what we see, it's unlikely that there'd be a rationale for imaging, at least early on in that case.
Right. So the accelerator effect that you mentioned earlier leads to things like injection, surgery, medication use. Let's talk about the dollar impact of that first. Do you have any sense on what that looks like in kind of, hard dollars and cents to us? Because healthcare is not free in the United States. We're all paying for it in some way.
Yeah, as soon as you start talking about costs, you have to first define that cost. The hospital, the insurance provider, the patient with large deductibles and out-of-pocket costs. Any of these kind of perspectives, the way you quantify what the cost is differs. But when you're talking about cost to an individual patient, this can run absolutely in the thousands of dollars, and that's not even taking into account lost time at work or other kinds of lost productivity issues, let alone just quality of life and enjoyment of recreational and social activities that are going to come along with the kinds of interventions that we're talking about, especially when we start to talk about surgery.
Do you have an idea of like a national number, like how much back pain kind of costs us as a national average almost?
There was a fairly recent publication in JAMA by some economists who used some interesting methodologies that I'd be ill-equipped to explain in detail, other than to say they took a very holistic approach at the cost to society, which is healthcare costs and these issues about lost productivity and wages and opportunity cost. And I can't remember the number, and if I try to recall it from memory, I'm going to get it wrong. So I'm going to refrain from the actual number. But what struck me about that article was that whatever that number was, it was higher than any other healthcare condition that's dealt with in the United States. So heart disease, diabetes, asthma, depression, things that we think of perhaps as more common, more costly, more impactful. Spine pain was higher than all of them. And there's several reasons for that. One of them is when you take a look at it from that kind of an economic perspective, unlike, let's say, heart disease or diabetes, where the prevalence tends to go up as people age, with back pain, it's often at its most problematic when people are in their prime working years. So the impact on work output and such becomes much more noticeable with something like musculoskeletal conditions and back pain.
Right. But we're not talking about thousands of dollars. We're talking about really billions of dollars to the
Yes,
system.
absolutely. Whatever that number is, it has a B with it.
Yeah. Opioids is, always on our radar. And when I think of some of the patients who I've seen with, low back pain and what they were prescribed in the beginning, very concerning. What does improper low back care look like with regard to its impact on our opioid epidemic?
Yeah. back pain has been historically, and I believe this is still the case, the most common diagnosis for which an opioid prescription is given. And that's despite now, really at least a decade or more of beginning to understand the problem we've created in the medical system with respect to opioids, the fact that they're not actually that effective for chronic back pain and other kind of chronic musculoskeletal conditions. And certainly the awareness of the onward effects on society and on the individuals who get these prescriptions has become much more front of mind than it was 15, 20 years ago. So back pain has been a major contributor to the prescription opioid problems that we continue to deal with in this country. And while there's certainly data that shows the prescribing behaviors specific for back pain have declined in some instances, there seems to be some rebound in that, particularly as we have been dealing with the effects of COVID. So data from the early part of the COVID pandemic and showed, perhaps understandably, to a degree, a shifting away from non-pharmacologic interventions that were not always available, back towards more reliance on pharmacologic interventions, and opioids being a part of that.
A lot of your work, your research centers around the role of the physical therapist in all of this. So physical therapist's role in, let's say, mitigating the use of imaging, the role of physical therapy, or the impact that physical therapy could have on our opioid epidemic. I guess since we're talking about opioids, let's just kind of go here first. Should we, as a profession, physical therapists, play a larger role in treating people with opioid use disorder? Because I think traditionally, there was this kind of approach that, well, this is someone with an addiction problem, an opioid use problem. They should see a mental health provider first. They should address that. And then if they still have a problem, they can come back to care for me, so to speak. So it was this idea of like, screen and refer out. Like it's kind of wash my hands of it. What's your take based on the research and where we're going with that?
You bring up I think a really excellent point and an important issue for our profession to think more about what our role is. I think there's definitely a need for us who are on the research side of the profession to look at this more carefully. And what I'm referring to is, as we've talked about physical therapy and opioids, we've often really framed it as physical therapy is the non-pharmacologic alternative to initiating opioids when a new presentation of back pain arrives in a provider's office. And that's accurate. That's something that physical therapists should and do advocate for. But our role in individuals who are long-term opioid users, or who perhaps have transitioned into some misuse behaviors or addiction, that we haven't talked as much about. And, a couple thoughts come to mind based on what you said. One is, we could have what is a hypothetical conversation about whether we should see those patients or not. The reality is we do every day. Physical therapists in an outpatient orthopedic practice are absolutely seeing these patients. The question is whether we identify them and then whether we see ourselves as having a role as part of their team of care. And I think just like any other co-occurring medical condition that we frequently see with chronic pain, we think about this as the spectrum that you laid out, that individuals who have what I would consider passive or less than ideal pain coping strategies that include opioids, perhaps a long-term opioid user, this is my opinion, there is a role for physical therapy as part of a management team to teach more adaptive coping strategies and help reduce the reliance on opioids for pain management for that individual. As we begin to move into individuals who have misuse or addiction issues, there's going to be some thresholds there where our role is more one of identifying the issue if it hasn't been identified, referring to appropriate medical care for individuals who are at these levels of this particular disorder, just like we would for an individual with a mood disorder or other kinds of co-occurring medical conditions. But I don't think we've thought about this quite enough as a profession and really talked about what is our role, how do we do this, are we training ourselves well enough Are educational programs dealing with this issue appropriately, et cetera?
Yeah, I saw maybe one or two sessions at this year's CSM in San Diego, but I don't think for such a large conference, I think that number is actually quite low considering the magnitude of the problem and the idea that we, as you mentioned, whether you want to or not, you're facing this in some way as a physical therapist at every level of the system, whether you're in education, whether you're treating patients, or whether you're involved in research some way. I just want to highlight just kind of something from your research. So I kind of pulled this from a study. So early physical therapy is associated with a decreased risk of advanced imaging, additional physician visits, surgery, injections, and opioid medications. And on average, costs people somewhere between, or cost the system somewhere between $2,700 and $4,793. So when people are referred, or when physical therapy is used appropriately as, let's say, first line care, it prevents the overuse of all the things I just mentioned, or the misuse of everything I just mentioned. Plus, it saves our healthcare system money.
So I'm a researcher, so I'm duty bound to point out the shortcomings of the designs of studies like this, and exercise caution about cause and effect sort of relationships. Obviously, you're reading things that I wrote. It's accurate in the sense that, and this isn't strictly things that I've done. When we look at this claims data and we look at, does physical therapy show up in the plan of care, and does it show up early or late, we tend to see these kinds of associations, particularly when we look at physical therapy that appears early in care versus late. If we look at physical therapy appearing early in care versus not showing up in care, some of those numbers shift a little bit, is particularly on the cost side. But absolutely, those associations are really compelling in claims data, that individuals who utilize physical therapy early in care tend to have less of these low value outcomes than when physical therapy gets pushed out further away. Now, that probably does say something about the patient as well as the care being provided by physical therapists. People who are amenable and want this kind of care is probably also showing up in that data. But I think, we, those of us in the profession, I think, can also recognize that the care itself is hopefully contributing to those outcomes.
Talking to physical therapists, I mean, this will probably relate to other professionals as well, like chiropractors, but how should we best evaluate an episode of low back pain in the clinic?
You mean evaluate the individual patient?
Yeah. Like if we're just kind of, obviously we're not going to get into like reflex testing and things like that, but in general, what should our approach be to the evaluation of someone who comes in with an episode of low back pain?
Yeah, I mean, I think to think of it broadly, there are people you could have on the podcast, probably have had on the podcast, who could talk more about the nuances of the physical exam, and understanding impairments and how they contribute to the presentation of low back pain. And that really is the bread and butter of physical therapy, right? Is the physical assessment of the patient's spinal condition. I think what we're becoming more appreciative of, recently, even quite recently, is a fuller assessment of what we could label as social determinants of health, or understanding a more sort of holistic perspective on the particular patient, to understand the context in which they're dealing with this pain condition and how that may be either facilitating or creating barriers to their recovery. And I think that's a skill that physical therapists are learning. I think I know we educate our students quite differently about how to interview patients, how to help the patient that is before you to connect other aspects of their life to pain and dealing with pain. But I think that's something that's still relatively emerging in our profession, is understanding how to put all that together with what still is the bread and butter of our profession, to do the very best service that we can for the patients that we see.
Because there could be a lot to put together for certain people.
Absolutely. Right? Yeah.
Because it's not really one, really what you're saying is it's hard to just put your finger on one contributing factor to low back pain. It's multifactorial, multidimensional.
Yeah. I mean, particularly when we're talking about individuals who have chronic or chronic recurrent kind of pain. It inevitably is impacting and being impacted by other aspects of that person's life. And that, introduces a whole level of complexity that I think, how comfortable we all feel in being able to sort through that, is variable. And there's a lot of issues that can come up in there that we have to at least prepare ourselves to know how to manage.
I agree. You've researched back pain now for a number of decades. What are you currently working on, and what should we be thinking about as we're kind of moving forward and looking at this condition?
Yeah, I'll go back first to a topic we were talking about just a moment ago in terms of physical therapists' role with individuals who are long-term opioid users, maybe into a little bit of misuse. I'm working on a couple of interesting projects of trying to think about how can physical therapists be more intentional and explicit about managing that type of patient with the goal of reducing opioid use. So one of those projects, we're particularly working with a post-surgical population. The other, we're actually looking mostly at how do we train physical therapists to feel comfortable with this. But the techniques that we're using are trying to integrate in mindfulness-based techniques, which have been shown to be helpful in people who have substance use disorders and problematic opioid use, in terms of increasing the attentional awareness on the part of the patient, and how do we integrate that with, again, the bread and butter traditional physical therapy approaches to people with back pain or post-surgical pain that they're important that we don't lose track of. So I'm really excited about that work. I think there's a lot to be done on helping to understand this, but beginning to even just survey physical therapists about their attitudes about this sort of thing is really fascinating. So that I'm finding very rewarding. Other projects that I have going on are, really focused a lot on these care delivery questions that we started out talking about. That, as a physical therapist, I've often focused a lot on what technique is the physical therapist doing, and that's interesting. But to step back and say, when people go to seek care for back pain, what starts happening, and how do we study what's the best pathway? That's become more and more of interest to me and other researchers, because it feels like that's really more where we can have hopefully a positive impact on the patient experience is, just these pathways of care that people tend to fall into. So that's also been really exciting work for me.
So is that I guess what you're saying there is we know that physical therapy has an added benefit, so to speak, but you're trying to dissect what is it about physical therapy? Because physical therapy physical therapy is a profession. It's not necessarily intervention. So you're trying to figure out, all right, what is it? Is it exercise? Is it manual therapy? Is it more the psychosocial part of things? Try and dissect that piece out of it.
Yeah, well, it's some of that, but it's also some of okay, as long as we put a few parameters around what physical therapy is and kind of keep it broadly in the evidence-based space, I'm going to shift my focus from not so much worrying about what exactly is that physical therapist doing to who are they doing it to and when are they doing it and what's happened before and what's likely to happen afterwards. And that's it's a little more 30,000 foot view of physical therapy versus, did you use this technique or that technique? And there's important research questions kind of across that whole spectrum. But for myself, I've become, more interested in where do we insert the physical therapy relative to other things, and what does that look like? What kind of outcomes does that get?
Julie, thanks for joining me this week. I think your research on low back pain, and especially how it kind of has informed what we do as physical therapists, is important. We'll of course look out for new research and new studies that you'll be publishing. Let people know how they can learn more about you and follow your work.
I guess I'm both old and a pretty traditional scientist, so probably the best place you can learn more about my work is in peer-reviewed literature where we publish these things. I'm not much of a social media person, but I do have a Twitter account at jfritz PT, and I certainly like to engage around interesting research and ideas in the field on that forum as well. So I'm always interested in what other ideas people have around these kinds of issues that we've been talking about.
Great. As I mentioned in the introduction, of course, you can find Julie at the University of Utah, which is the center of her work around low back pain. At the end of every episode, I ask you to share this with your friends and colleagues on Facebook, LinkedIn, Twitter, wherever anyone is talking about conservative care of low back pain and physical therapy's role in the treatment of low back pain. Again, I want to thank Julie for joining us this week. I'm Dr. Joe Tatta. Make sure you subscribe to the podcast so you can receive the latest episode each week. I'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's integrativepainscienceinstitute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.